I'm very excited to give this talk, and I don't think I'll hopefully won't need the full 25 minutes, so we'll have maybe potentially even more time to chat. I'd love to hear everyone's thoughts, questions, and opinions on this work. As you'll see, this is the start of what we hope to be an ongoing project, so any of your inputs would be very helpful. Before I start, I think it'd be useful just to introduce the team. This is kind of our slogan, which is we're a team of social scientists and health economists who design and evaluate interventions to improve the delivery and use of healthcare. And a lot of this work was done primarily by my two doctoral researchers, Caterina Favaretti and Vasanthi Subramania Pillai. And the future of this work will be done by Michaela Teilman, who'll be joining our team as a postdoctoral fellow sometime in this year. So I think it was nice to kind of showcase that we have both the work and where it will go with Michaela afterwards. I was hoping that by the time we had this talk, I would have our group's website ready, but I didn't get my act together in time. So for now, please just go to my personal website, but it will link to our team's website very soon. And that would be really where you can find out more about the type of work we're doing and the projects that we are engaged in. Okay, so as a very brief motivation, I don't want to spend too much time on this. Uncontrolled blood pressure or hypertension is the focus of what we are looking at today. And we looked at it because it substantially increases the risk of stroke, heart disease, and kidney disease. And to give you a sense of how important it is in the Indian context, this is a paper that was done by my colleague Jitin Verghese using nationally representative data from India. And what we're showing here in these graphs is what's known as the continuum of care for hypertension. This is an idea that's actually borrowed from the HIV and tuberculosis world and has been applied to chronic diseases like hypertension. And what it essentially shows is how many people in the population have the condition, and then how many are advancing to the subsequent stages. So in our case, we see that 28% of adults 18 and above in India have hypertension, which is already a pretty high number. And if you look at older age groups, like among the 40 plus, this gets really high. It's almost half of people above age 50, for example. Among these individuals, though, you can see right away that there's really huge drop-offs in diagnosis, treatment, and control rates. So if you look going across all of it, 28% of adults have hypertension, but among this group of individuals, only about 8.5% actually have their blood pressure under control. So that's the gap between the first and the last bar. So really, this shows that there's a huge burden of uncontrolled hypertension in the country. And this, importantly, is not isolated to just urban areas. So if you look at panels B and C, we split it by urban and rural. And you see that although the rural is a little bit lower, we see similarly high levels and high levels of poor control as well. So as you might expect, seeing this much uncontrolled hypertension, this is reflected in mortality in the country. So cardiovascular diseases like stroke and heart disease have been the leading cause of death for a long time now in India. And this is true in both urban and rural settings. So it's not, again, just an urban phenomenon. I'm going to convince you today, hopefully, that one of the most important contributors to this pattern, this high levels of uncontrolled hypertension, is poor retention and care and poor healthcare seeking for hypertension. So we'll start with the importance of regular visits. They are particularly important for hypertension and cardiovascular disease prevention, but they're also important for several other conditions that we can talk about at the end. And here I'm talking about someone visiting a doctor regularly, and this is usually in the context of primary care. This is important because even starting right away with diagnosis, getting a diagnosis of hypertension takes multiple visits. Because blood pressure kind of varies a lot over time, clinicians generally don't make diagnosis decisions based on one point in time. Rather, they use multiple measurements. The challenge is, though, if people are not coming for these multiple visits, they'll remain undiagnosed. Once an individual is diagnosed, though, these visits are really important for titrating medication. So making sure that the correct medication is used to get people's blood pressure controlled and that this medication is tolerated so it doesn't have too many side effects. In the long run, one of the most important functions of follow-up visits are to deliver refills. So people generally don't get lifetime prescriptions. And although medications need to be taken lifelong, the prescriptions generally are for like 1 month or 3 months. And so individuals must make regular visits back to the facility to meet with the physician who will measure and ensure that their blood pressure is controlled, monitor issues of adherence, and deliver a subsequent prescription for their refills. So if individuals start missing these visits, they're at risk for stopping medication and losing blood pressure control over time. And that's a pattern that in our other work, we really see evidence of, that people tend to lose blood pressure control over time. So in the Indian context, we see very, very low demand for preventive care for hypertension and related cardiovascular conditions. I'm going to highlight two studies here. One is by our colleagues, Nikhil Venkateshmurthy. They ran a very large trial called the Uday study, where they actually went to individuals' homes, screened them for hypertension and diabetes, and referred people who had a suspected high measurement to a health facility for diagnosis. They found that just 6% of the referred individuals went. So even though they identified a lot of potential undiagnosed burden in the population, most of those people never connected with the health facility. In another work by Das in Punjab, which is the state that we'll focus on here, they look at individuals with diagnosed hypertension, and they find that less than 50% of them attend their routine follow-up visits. So we're seeing this challenge at both the diagnosis and the return long-term retention levels. When you start to ask, why is this? I think this is interesting that the reasoning behind this tends to split across disciplinary lines. So we see a different set of explanations arise in public health and global health than what you would see in economics and behavioral science. And I think it's kind of interesting to think about how we could bridge those differences, or to what degree all these factors matter. But in the world of public health, you typically see awareness of a condition, knowledge of its risks or importance. So knowing that it's an important health risk, access, and cost as the main explanations that people put forward for why you don't seek care and have high levels of undiagnosed conditions. In the public health world, this idea of awareness is a little bit generic. It's often used to kind of encompass everything, which is something we'll come back to in a slide or two. But here we should separate between awareness of a condition, that is me knowing that I might have hypertension, and knowledge of its risks, which is me knowing why hypertension is bad and why I need to take action. On the other hand, if you look at the explanations that come out of the world of economics and behavioral science, you get a lot of these behavioral bias type explanations, things like present bias, forgetfulness, and cognitive bandwidth. And collectively, these things can kind of be summarized with the idea that people have a limited ability to think about and make decisions. And decisions that are less salient, such as going for preventive care, often get deprioritized mentally by things that are more immediate. So more immediate things could be the need for income, the need for childcare. If you have acute illnesses that have symptoms, often those become more important than preventive care, which is often asymptomatic. So the literature here really emphasizes the fact that preventive care, because it's often needed when people feel healthy, gets mentally deprioritized. So that individuals might actually know why it's important. They might be able to access it and pay for it, but still not use it because it's just not something that they're able to dedicate mental bandwidth towards. There's these two schools of thought, but in our survey of the literature, the one thing we saw is that interventions that target these barriers, both the public health and econ ones, often don't improve the use of preventive care. So interventions to improve knowledge and awareness or access and cost often still don't lead to people using more care. And in economics, there's a literature trying to correct for these type of present bias type scenarios and forgetfulness through things like reminders. And they tend to have kind of mixed to small effects. So what we put forward here is that we think there's something else going on that might be acting in addition to all these other barriers and creating the patterns that we see. And for us, we think it's the idea of health-related misconceptions. So here, a misconception, to be clear, is an incorrect or false belief about a health condition that often stems from faulty reasoning. So it's not just a lack of knowledge, but it's actually an incorrect belief that one arrives at through potential incorrect reasoning. So misconceptions around prevention, for example, might stem from faulty reasoning that comes from prior experiences with infectious conditions. So to kind of make this very clear, with infectious conditions, you often feel sick. Those symptoms prompt your belief that you need care. You're given a short period of treatment. The symptoms tend to go away. You stop your treatment and you're cured. That's it. Now you're no longer, really don't require care. But you can see how this can go wrong if you start applying this type of logic to things like hypertension. First of all, the idea that if you don't have symptoms, you don't need care that's an incorrect kind of conclusion. Sometimes people falsely attribute symptoms to hypertension, things like headaches, and they find that when their headaches go away, they believe that they've been cured and no longer need care, which is also incorrect. And you also see that these kind of cluster of things are going to be very difficult to change because they're tied not to necessarily just a basic set of knowledge, but they're tied to people's prior experience with infectious conditions. So changing this is a challenge that we face pretty hard in this project as well. Today, we're talking about misconceptions for hypertension, but it's important to say that they're really important for other health areas too. Misconceptions around vaccines, for example, are a huge driver of vaccine hesitancy. We also see things about misconceptions about maternal-child health. Beliefs about what babies should be given and how to treat diarrhea can be very prominent, and they can really hinder the use of evidence-based treatments and practices. So to correct or to address misconceptions, there's a literature that's growing now that shows that traditional information interventions won't be effective at correcting misconceptions. That is to say, our kind of standard public health approach of giving people knowledge and saying, hypertension is bad, it leads to stroke, you should do something. If people hold misconceptions, such messages often don't work. And part of the reasons theoretically are this idea of what's known as the continued influence effect, which is that misconceptions tend to continue to influence someone's thinking, even if they start to experience pieces of information or evidence that corrects them. And in its absolute worst case scenario, you could end up actually reinforcing false beliefs. And so individuals double down on their negative beliefs when they're presented with alternate information. Debunking strategies have been put forward as a potential solution to this. And so in contrast to traditional communication strategies, a debunking intervention, you acknowledge a misconception, state that it's false, and then you provide the correct information. The major challenge that we see with this, though, is that most of the literature on debunking is from psych laboratories and kind of university studies or online studies. We have very little evidence on the effectiveness of these type of debunking strategies in real-world contexts. So that brings us to what we were looking at. Our two questions for today. We wanted to see whether bundling information debunking misconceptions around hypertension with a traditional reminder could reduce missed follow-up visits. And because we're combining a reminder with debunking information, we wanted to know, is any effect that we observe, is it moderated through a change in beliefs? Did we manage to correct beliefs? We did this in the context of two parallelly run randomized control trials in the outpatient wards of two sub-district hospitals in Punjab, which you can see highlighted on the map there. The reason we focused on two different populations has to do with our messaging approach. So we saw that among all the people that we recruited, many of them had smartphones, but many of them also had just feature phones. And we didn't want to exclude the people with feature phones for whom this is equally relevant and who actually tend to be the older people as well. And so we ran two interventions. We ran one intervention where we delivered our message through WhatsApp to those people that had smartphones. And for those without smartphones, we delivered the same message through a phone call from a staff member at the hospital. So they didn't need to have WhatsApp, we just called them directly. The design is quite simple, and I have to say here that this study was really made possible by Noura Health. There were collaborators on this project. They're a healthcare organization and research organization in India, and they were the mechanism through which we started working together in Punjab. So our trial was quite simple, so I don't want to spend too much time on it. We randomized individuals to either usual care, which in our setting was no message or reminder, or our enhanced reminder, which I'll show you on the next slide. This enhanced reminder was either sent as a WhatsApp message or a phone call based on whether people had a smartphone or not. Our primary outcome was, did they show up for their physician-requested follow-up visit? And I'll show you in the next slide how we actually measured that. That was not the easiest thing to do. Our secondary outcome, though, is to understand whether we actually managed to correct hypertension-related misconceptions. So we measured beliefs around hypertension using an open-ended questionnaire, and we saw whether beliefs changed differentially among those that got our message compared to those that didn't. This study took about 1 year in total to collect data for, and this was actually a challenge for us. The recruitment was much slower than we anticipated. And in the end, we ended up with 851 individuals split across these two studies. This is an important limitation and one that I'll touch on in a little bit. So a major challenge for us, healthcare facilities in India do not really maintain record systems. So how would we know if somebody came back or not? This was not a trivial challenge, and ultimately what we ended up doing is hiring a receptionist for each of our facilities. And you can see how we kind of stationed the receptionist and the data collector. So we stationed the receptionist in the doctor's consultation room and a data collector outside. This allowed us, so after someone met with the doctor would determine whether they're eligible for the study or not, and then they would send them to our receptionist, who would collect information on every patient that met the doctor. If the doctor indicated that the person might be eligible and the receptionist checks confirmed that, they were then sent to a data collector who administered the kind of baseline questionnaire. So it was a pretty tricky operation because of the fact that these settings did not generally have records. So we had to do everything in-house and collect it ourselves. This was the slip that we gave all doctors, and this is how we basically figured out whether patients were eligible and got some key information. So for every patient that the physician saw, they just checked this slip that said whether they had hypertension or not. If so, when they asked the patient to come back for a follow-up visit and for what reason, and their systolic and diastolic blood pressure readings if they were measured. This information was entered by our receptionist and data collector, and it's attached to each patient that was eligible for our study. Here's the timeline. As you saw on the previous slide, people could be asked to come back after 7 days, 14 days, or 30 days. In our setting, actually, most patients were asked to come back within 7 days. And that really reflects the low medication stock in these facilities. They just didn't have enough medications to give people 30-day prescriptions. So people were kind of given weekly or 2-week supplies and asked to come back. Depending on when people were asked to come back, we sent them the reminder 2 days before their follow-up appointment. At the end of the study, so after all possible kind of follow-up appointment times could happen, we conducted an N-line survey with all our participants, which we did over the phone. Here's where we measured hypertension-related beliefs again to try to see if they changed because of our intervention. Our intervention, as we alluded to earlier, was what we called an enhanced reminder. And that is a reminder that combines a traditional kind of approach to reminding people about a visit with debunking information. And so if you look at the reminder 1 here, the first part of the text at the top is just a standard reminder. It's just telling you you have to come back on this day to refill your medication or get your blood pressure checked. This is traditionally what you would see in a reminder study. The information below, though, is where we introduced our debunking information. So here's where we said something like, many people are surprised to know this, but you need medications and care even if your blood pressure has come down to normal or you've finished your current medications. You may need care even if you don't feel symptoms or headaches. So we tried to kind of emphasize that this belief is false and that this is actually what you need. For the phone call, this was all that people got. We only made 1 phone call. For those randomized to the WhatsApp message, they actually received 2 messages. And so the WhatsApp people got a second message here that just kind of reinforced the content of the first. So here, this is really combining a very standard reminder that you would see in a lot of studies with this kind of debunking information to see if we're able to change beliefs. Jumping right into the findings, our first main result is that we found evidence of really large misconceptions at baseline. So before we randomized anybody to receive anything, we measured their beliefs. And here's what we saw. About half of people said they should only get their blood pressure checked when they feel ill, which is wrong and kind of related to that infectious disease idea. More than half, so 63%, said if their symptoms went away, they could stop coming to the facility to pick up their BP medications and that they no longer required checks. So that's really troubling, right? If people believe that they're resolved, they will essentially disengage from care. And around 40% of our participants were not aware that hypertension medication should be taken daily and lifelong. And so these are pretty widespread misconceptions, 50%, 63, and 40. And these are all related to that mental model idea that we introduced earlier, then that people might be applying a kind of infectious disease way of thinking to guide their decisions around chronic diseases. And that can lead to these misconceptions and faulty decisions. Our second main result, which is just descriptive again, is very low follow-up visits. So we confirm the challenge that we saw in previous studies. Among our participants, only about 20% of them showed up for their physician-requested follow-up visit. So to put that in context, all of our participants had diagnosed or suspected diagnosed hypertension. Only 20% showed up. So that tells you that for 80% of participants or patients, they were not getting their medications, not receiving follow-up visits, and likely therefore had uncontrolled blood pressure. So these two slides right away kind of outline the core challenge that we spent a lot of time thinking about, that there's really widespread misconceptions, and that these misconceptions may be contributing to or be one of these contributors to this very low follow-up visit rate that we see. So ultimately, though, the big question is, did our intervention work, and did it work the way we thought it would work? And the answer is kind of a bit of all of the above. So I'll show you the results first for our phone call reminder. So here, these are people that did not have a smartphone. So they received a call from a health facility administrator that we hired before their appointment. And this phone call had both a reminder of their upcoming visit and that information trying to debunk misconceptions around hypertension. So you can see that among people in the control group who did not receive the phone call, only about 20% of them showed up for their follow-up visit. If you take an intent to treat approach and look at everybody that was assigned to receive the phone call, 31% or close to 32% actually show up. So we're really substantially improving follow-up visit rates, which I think is a really kind of a high-level important finding here, that this is essentially representing a 50% increase or a 10 percentage point increase on the control mean. I think that's worth pointing out that this is much larger than a lot of previous reminder studies, and the next slide may give you a hint as to why. But sticking with this, because we did a phone call reminder, not everybody that was assigned to receive the phone call actually got it. People could not pick up, their phone calls could get sent through spam filters, so about 20% of people actually didn't end up receiving the call. If we then use a treatment effect on the treated approach with instrumental variables and just look at what was the effect among those people that actually received the phone call, we see that 35% of them showed up. So this is about a 15 percentage point increase. So overall, what we're seeing is that for those of our participants that received the phone call reminder, they were substantially more likely to show up for their follow-up visits, which I think is a really kind of promising result that came out of this study. However, if we now turn to the WhatsApp reminder, remember the same idea here, about 20% of people are showing up. Do people that get our WhatsApp-based reminder, so rather than a phone call, they get the information over 2 WhatsApp messages. What was the effect of that on follow-up attendance? And that was an extremely precisely estimated 0. So we were completely unsuccessful with the WhatsApp messages. It wasn't even like it was a positive coefficient and a wide confidence interval. I think our coefficient was 0.0 something. And I think this starts to give us some clue about why a lot of the reminder studies are not very effective. It seems, at least taking this comparison between the phone call and the WhatsApp studies, that how you send reminders really seems to matter. Something personalized like a phone call seems to produce much bigger effects. These results, unfortunately, are not directly comparable because they are among different study populations. So it's not a multi-arm trial. These are 2 separate trials. So we have to be a little bit cautious about directly comparing the 2 results. But the content of the reminders was the same, and they were done in the same location. And so we have some idea, at least, or some confidence that this seems to matter. And this is something we'll come back to. So the phone call really worked. The WhatsApp message didn't work at all. The question, though, did this work by correcting people's misconceptions? To look at that, what we did was we asked people 7 hypertension-related questions. They were all open-ended, and we then coded their responses into whether the response was correct or incorrect. We then added up the number of incorrect answers that each person gave from the 7 questions and created what we call a misconception score. So here, like when you look at the control group and see the number of 2, that means among the control group, on average, people had 2 out of the 7 misconceptions about hypertension. We looked at specific questions and different combinations, and I'm happy to talk about that as well. But just so we have a simpler comparison, we created this index rather than looking at each question individually. And so what we see here is that despite the very large effect of the phone call reminder on attendance of follow-up visits, it was not effective at all at changing people's misconceptions. So at Endline, the treatment group and the control group both endorsed about 2 out of the 7 misconceptions with really no evidence of improvement. And so kind of at a high level, taking our 3 experimental findings together, we did find a big effect of the phone call reminder compared to basically no effect of the WhatsApp reminder. But this phone call reminders effect doesn't seem to have gone through changing beliefs or misconceptions. People's misconceptions about hypertension, which were really prominent at baseline, continued to remain at endline, regardless of whether they saw our debunking message or not. So before we go to the conclusions, a couple limitations that are important here. As I mentioned, our sample size was smaller than we initially planned. We had challenges recruiting individuals. And so this means that because of our smaller sample sizes, we don't have a lot of power to detect subtle effects. So really, we can be looking at only large effects on follow-up visit attendance or on misconceptions, and that is an important limitation. We also only conducted the study in 2 facilities. Maybe this is something we can talk about in the Q&A, but actually collaborating with governments to run interventions like this was a big challenge for us. And we felt it was not easy for us to manage or even work in more than 2 or 3 facilities. So this maybe hinders the generalizability of our findings. And for those of you that are maybe design nerds or randomization nerds, you might have wondered from the beginning why we didn't use a 3-arm design. Really, you would think an ideal design would be control, traditional reminder, and traditional reminder plus debunking. Such a design would allow us to isolate the unique effect of debunking as opposed to just the effect of the reminder. And this was purely a kind of budget and logistics constraint. We just did not have the sample size or the money to do a 3-armed randomized trial. And so we did this kind of combined approach and tried to tease apart the different mechanisms using the questions about misconceptions. So we almost looked at it from a mediation perspective rather than a design-based hypothesis perspective. But I'm happy if people still take issue with this, and this is something we can talk about. So our overall interpretation was that misconceptions are a major challenge and that simple debunking messages don't really seem to correct them. That isn't to say debunking doesn't work. I think where this is pushing us is that we need to investigate more intensive communication strategies to correct beliefs that are so widespread and so entrenched in the society. This kind of peculiar finding, how come the phone call was so effective but the WhatsApp wasn't? We have 2 hypotheses for that. One might be that a phone call from a health facility person might just be perceived as more salient and trustworthy, and it's just something that you remember more. The other might be that this idea of social accountability, that if you just receive a WhatsApp message, it's very easy to ignore it and not feel like you're letting anybody down. But people might feel more pressure to listen to somebody if the information and the request is coming via a phone call, and they're really speaking to someone who's personally asking them to do something. As I said, we can't really directly speak to these mechanisms in this study, but I think this is something that came out of our 2 trials that we want to pursue further. It really does seem like how you deliver these messages can be really important for the effects that they have, and that's something we want to pursue further. We are taking a positive spin on this ultimately and saying that we're not going to give up hope on the idea of reminders or debunking, but rather that a phone call reminder that incorporates maybe a more successful debunking or belief correction strategy can have even larger effects. I think we were really happy to see that the phone call reminder had such a big effect, even if it didn't affect misconceptions. That kind of tells us that if we're also able to correct and change beliefs, maybe we can produce an even more meaningful effect. And that's kind of where we're going with this. So I'll leave with kind of these last couple thoughts. Our next step is we're planning a systematic review of belief-correcting interventions. This is really a literature born out of psychology and the communication sciences. And what we want to know, do some approaches work better than others? And what are the features of these interventions that are associated with larger impact? For example, if they're sent from a person versus a message, does that have a larger effect? If it uses multiple messages versus one, if it's interactive versus passive, what are the kind of design elements associated with these communication strategies that make them more effective? We also are planning a population survey to follow this up of the information environment. So this would really be a survey among older adults in India at the community level, where we try to understand all the sources of health information that they're exposed to. So this could be traditional kind of media things like news and billboards, but it could also be WhatsApp messages, and it could be their neighbor telling them things. We really want to know where are all the kind of places from which people get health information? And importantly, though, which of those sources do they actually trust more than others? The idea being that if we take these two, we might be able to try to understand where these misconceptions are coming from and which people are kind of leading to the formation of these misconceptions. And kind of similarly, while these are kind of the exposure side, where people are being exposed to information, if they actively want to know something or if they need to seek health advice, who do they go to or where do they go to? The idea behind this is that this will help us to triangulate the results to design and evaluate more effective correction communication strategies. And one last thing I should mention here is that we're actually planning another randomized trial that should start this summer to address this issue I talked in the beginning of people not even showing up for that diagnosis visit. And there we're going to try to put into play some of these more intensive misconception correction interventions there as well. So we haven't solved the problem, but really I think what we've done is created a long-term and hopefully impactful research agenda for us. And this is something that I'd love to talk with you all a bit more. So if you're interested in the two papers that this is based on, one was published in BMC Public Health and the other in Social Science and Medicine. They're both open access, so you should be able to find both of them for free. I'm also happy to take any kind of questions or comments on them by email. So if you didn't get what you were looking for in the Q&A here, please feel free to email me. And maybe, Esther, my last slide, do you want me to talk about the global health research is, or should we do this later?
Yes, please go ahead.
Okay, so this was a request from the Global Health Academy to kind of put into words what I think global health research is. And to be fully honest, I quite struggled with this because in the global health course that we teach here at TUM, we actually advise students to be more specific than to say global health. So we say say the country and population. If you're working on India, say India. If you're working on Rwanda, say Rwanda. Be kind of more context specific. I think this is also challenging because, of course, when you meet colleagues in places like India, I don't know whether if they consider what they do global health or if they consider it just public health because it's in the country that they live in. So I struggled a little bit to put this into words, but I think the best that I can do, which isn't great, is that it's research in context characterized by high levels of vulnerability. So this could be poverty, violence, anything like that, low access to healthcare, and poor care quality. So you'll notice that mine is kind of very healthcare and social focused, and I think that reflects my bias. I said nothing about the type of infections or the tropical diseases that are in these areas because that's just not my area. I think for me, this is more how I view global health. And I will also say that if you haven't told by now, I am American, and many of these definitions could apply to contexts in the US. So I want to kind of caution against drawing a comparison about this is just for certain types of countries. I think this really could apply to many places, and even in the United States or Europe as well. But I'm happy to hear criticisms on this definition. So with that, thank you so much. And of course, if you have any questions or anything, please feel free to email me. I think my email should be part of this, or you can just Google me and find our email there. Thank you.